Good afternoon and a very warm welcome to today's ISNTD Connect. My name is Marianne Compre. I'm speaking from the International Society for Neglected Tropical Diseases. I'm speaking literally from sat here in London in the UK. And it's my huge pleasure today to open this session where we will be taking a closer look at the interplay between gender, trichiasis detection, and in a broader sense, how this relates to trachoma and preventable blindness in general. I'm really excited today to welcome an amazing team of researchers who have been going into communities to really shed some light in a very practical sense on these relationships, and recently also published a paper on understanding the role of gender in trichiasis case finding in Tanzania. So without any further delay, it's my pleasure to welcome very warmly our colleagues from the Kilimanjaro Centre for Community Ophthalmology. We will be hearing from Dr. Robert Geneau. You are Executive Director at KCCO. Welcome, Robert.
Thank you for having us today.
Thank you so much for being here. And presenting with you is Mrs. Elizabeth Kishiki. You are Childhood Blindness and Low Vision Coordinator. Hello, Elizabeth.
Hello, everyone.
With a wonderful echo there. That was a very dramatic entrance. Excellent. We'll also hear from Dr. Fortunate Shija. Fortunate, you are Project Coordinator at the KCCO. Welcome, Fortunate.
Thanks. Hi. I'm still connected with my computer, so I'm using Robert's for now until it's still searching. So hi, everyone.
Hi. I feel like we're all almost in the same room. It would be nice. And joining us as well as a consultant with KCCO and also from the from PEAK, the organization, Mrs. Grace Mwangi. Thank you for being here, Grace.
Thank you, and hello, everyone.
Hello, everyone. I'd like to welcome as well everyone in the audience. If you have a few minutes, please don't hesitate to say hi in the chat. We'll be using the chat to ask any questions or exchange comments or observations, experiences. Please let us know who you are and where you're connecting from, and it'll be wonderful to hear from you. So without any further delay, let's take a closer look at the relationship between gender and understanding how that impacts in a positive or negative way on trichiasis case detection. And thank you so much for sharing your amazing work right from the field. John Akani is saying hi, Yafsha Kayum is also saying hi, and thank you for joining us as well from around the world. So we're just getting the presentation ready, and with no further delay, I will hand over to our wonderful speakers. Thank you for being here.
Thank you very much. So again, it's a pleasure to be with you today. So I'm just going to say a few words about KCCO first. So we work in 7 countries, but our main office is here in Tanzania. And so we're joining you from Moshi and Kilimanjaro region. And we also have an office at the University of Cape Town, where I'm also affiliated as an honorary professor, and where we have a WHO collaborative center for trachoma. So we're going to be doing this as a team. So I'm going to get started with just a few first slides, and then my colleagues will continue with the presentation. So trachoma is still implementing Tanzania is still implementing interventions for trachoma. There's just a few districts left with MBA, with Zithromax, especially near the border with Kenya, where there's persistent active trachoma. Some of us in the same room, just to make sure there's only one mic open. But the bulk of the work, there's still a lot of work to do to reach the target for TT. And we've worked in several districts over the past few years. So Kennedy, that is one of the districts that was included in our study, is a district where we've completed the work. But this year we're still doing the TT case findings in Geneau district in Tanzania. So this is just a reminder, refresh your memory. So for trachoma, the 3 criteria to validate elimination as a public health problem is to have a prevalence of TF in children 1 to 9 for active trachoma that is below 5%. And for TT is to have a prevalence that is less than 0.2% in adults that are 15 years and above. And those have to be cases that are unknown to the health system. And maybe this is something we can come back to because it's relevant for this presentation. And finally, the third criteria is that there is evidence in the dossier that countries submit to the WHO that they have put in place the service delivery to treat incident cases of TT going forward. So there are 3 ways once a trachoma in endemic district they have completed intervention. There's 2 ways to validate if elimination has been achieved. And one is to do a population-based survey with tropical data at the district level. But now, since 2018, when there was a global trachoma scientific meeting, it was decided that full geographic coverage, so meaning that all people 15 and above in a community have been visited by a case finder and then subsequently been managed, that this is an appropriate way of documenting elimination. Or a third way is with geospatial analysis, and there are specific situations where this may be the best option. So, despite the fact that TT case finding is now a strategy that is used in multiple countries, it can be used ahead of a survey. But like I mentioned, it's also used now as a way of documenting elimination through documentation of full geographic coverage. There is not a lot of literature published. It's emerging, but there's not a ton of literature looking at the success factors or predictors of achieving good outcomes, which we're going to see the list of indicators that we've used for this study. So some of these factors may be the quality and length of the training of the case finders. That's one example, the quality of the supervision. But central to this study was the question as whether it was making any difference at all whether the programs were recruiting male versus female case finders, for example, in different settings. So that's the background that we wanted to provide. So now I'm going to turn it over to my colleague Elizabeth for the next few slides.
Thank you, Robert. From the presentation, from the work itself, the research work that we did, looking at the research narratives, we had questions that we were looking the answers for those questions. And our main research question was, like, what are the factors that include social, programmatic, motivational, etc., that results in female or male case finders being more productive and effective than male case finders. So in our narratives...
Apologies, I just want to check, are you getting an echo with the people online when Elizabeth is speaking?
Just a very slight, not as bad as when right at the beginning, then you quickly switched off a microphone. We could just get a tiny bit, but it's not personally, I don't think it's too distracting. I don't know how the audience feels about that.
I may just ask Elizabeth to come to my computer because she's using some headsets, and this, I think this may be the cause.
Got it. Okay. Well, thank you so much.
Can you actually use the meeting and just use my computer?
Okay.
This might take a few minutes, and actually we're very grateful, Robert, that you're thinking of our listening comfort. It's very kind of you. think we're nearly there. In the meantime, that gives me the perfect opportunity to send a warm hello to Nathan Binene Kayeye from DRC. Hello and welcome. Edward D'Antonio from the United States. If you would like to hear about drug discovery in neglected tropical diseases, Edward D'Antonio was our speaker last week with the recording on our website. And also a big hello to Yashfa Qayyum from Pakistan. Oh, perfect. I think ready to go, Elizabeth?
Yes.
Yes, then I shall disappear.
Now it's Elizabeth speaking, not Robert.
Oh, yeah. Great.
So I was taking you guys through the research question that we were trying to answer. And we were looking at factors that result in female or male case finders being more productive and effective than male case finders. So those were the question that we were looking at, and together with the other research narratives, we had specific objectives, 2 of them. One was to determine the productivity and effectiveness of male vis-a-vis female TT case finders. And we're looking at the population covered and examined in terms of adults, the number of suspected TT cases identified, proportion of suspected TT cases coming to outreach, and those with TT confirmed as managed. And the objective number 2 was to understand better through the use of qualitative research method, the range of factors that may explain gender differences across TT case finding productivity indicators. That is including how gender-related factors are associated with different case finding approaches and strategies. We had some indicators. We were looking at the number of the percentage of households vis-a-vis the percentage number of adults in the household, the number of population examined, and we were looking at male and female, people listed as suspected trichiasis cases, looking at men and women examined, the suspected cases who attended outreach, the suspected cases confirmed as having trichiasis, confirmed cases accepting surgery or other interventions. That is the number of percentage of male and female confirmed cases, and the assistance to facilitate compliance with follow-up. So those are the indicators we were looking at when we were trying to answer our question. So I would hand over to Grace so that she can continue with the start setting and the rest.
Thank you, Elizabeth. I hope I'm clear, Marianne. Okay.
Yes, absolutely.
Okay, great. All right.
Thanks.
Okay, so hello again, everyone. I'm going to take us briefly through the methods that we use for data collection. But before then, I'd like to just highlight where this study was conducted. So out of 18 districts in Tanzania, which were involved in case finding activities at the time of this study, 2 districts were selected for primary data collection, and those districts were Chamwino district, which is in Dodoma region, with an estimated population of 330,000 people. And the second district was Kilindi, which is within Tanga region, with a population of 236,000 people. Due to the importance of studying case finding activities among population which are constantly migrating, wards within Maasai communities were selected in Kilindi district. So we were able to gather some of the unique factors that could be affecting case finding among these migratory populations. So now I'm going to talk about the two data collection methods that were used. The first one being quantitative data collection, whereby we took all TT case finding output data as well as outreach data from the two targeted districts, and these were assessed for this study and summarized with descriptive statistics. Before producing the descriptive statistics, all this data was entered into an Excel database and then checked for accuracy. And then we did some analysis and produced the descriptive statistics that some of them you'll see in the next section when the findings are being presented. For this purpose, we took, for Kilindi, we took data from 2021 up to May 2022. And for Chamwino, we took data from 2016 all the way until May 2022. For the qualitative aspect of this study, data was collected through direct observation, and this was observation of training activities when case finders were being trained, and our teams also shadowed the case finders as they conducted case finding from house to house. We also use semi-structured interviews to interview different groups of people, among them case finders, community leaders, implementing partners, among others. And finally, we use focus group discussions to just gather more information from the key informants or from selected key informants. In each area or in the two districts, the study team recruited study participants. Among these were male and female case finders. We tried to balance between male and female where possible. There were community leaders interviewed or involved in focus group discussions. We had staff from implementing partners in the two districts. We also had district NTD and trachoma officers who were involved in this study. We had TT surgeons, and finally we had trichiasis patients who were also involved in this study. I'm now going to hand over to Fortunate to take us through the key findings from this study. Thank you.
Hi, just checking if everybody can hear me well, Ariane, and everybody.
All clear from our side.
Great. Okay, so we've heard from my colleagues, and we've had a little bit of an overview of what we did through the process of the case finding studies. So I'm going to share with you some findings that we think may give you an overview of what we actually came across. So first of all, I'm going to give a general overview of the number of households covered, comparing both male case finders and female case finders. And this is an analysis that was done both districts combined. Chamwino district and Kilindi district were combined together, and the female case finders from both districts were compared from the male case finders from both districts. As you can see from this presentation of the table here, it looks that there was no any significant difference on the average of the households covered between the male case finders compared to the female case finders for both districts. And we went further down into now comparing different proportions of men and female presenting for screening and operation. So as we have seen from this presentation here, we are comparing the suspected men presented for the outreach, comparing the male and female case finder for both districts now. As you can see, there's not any big difference from both. Like the suspected male by the female case finders presented the same compared to the ones that were suspected by the female case finders. Also, the suspected female, the same thing. And also the proportion of those who were operated of the suspected people, male and female, we are more or less the same for both female and male case finders. There's a little bit of a difference in the number of proportion of women who were operated. It wasn't very significant, but at least we had a little bit more women operated that were referred by the male case finder, and the difference was not very significant. We went now into further now trying to put the two districts separately. As one of our colleagues had mentioned earlier on, we had picked Kilindi because, and we specifically went to the Maasai community because it has some unique differences in terms of culture and also the terrain and also the general activities. They're the nomadic population, so they tend to move from one area to another, expecting maybe we may have some differences in the performances of the females. Now going further, like in a general picture, there's not so much difference, but there's a little bit difference in each district. As you can say, the number of case finders trained was mainly in both districts, in Kilindi and the Chamino district. We'll furthermore maybe know why that difference, but generally the difference is I mean the reasons are more or less the same. And also the average of numbers spent on case finding, there was less number of case finding for the case finders, general female and male in Chamino district, compared to the number of days spent for case finding in Kilindi. However, for comparing the two female and male case finders, it's no significant difference. It was more or less the same numbers. You can maybe ask yourself why double the number of days were spent in Kilindi compared to Chamino. As we had mentioned earlier on, there could be based on the difference in terrain and also the population. The Kilindi population is more of a nomadic population that was a Maasai, and they tend to live in a scattered manner compared to the ones in Chamino, where houses are packed in like they're clustered together, and also so it makes it easier for a person to go to more houses in shorter periods compared to Kilindi. However, it doesn't make any difference based on our study when it comes to either it's a female or male case finder used in both areas. We come to the average number of household covered. It's more or less the same. There was, of course, more numbers of household covered given the time in Chamino compared to Kilindi in general. Also, it's based on the previous explanation that I've given. However, you may notice a little bit of more numbers of household covered by the female case finders in Kilindi, which we may have some few reasons, like maybe they were more committed or they didn't have a lot of other things to do, but it doesn't make any significant difference when we put it into analysis. The same thing on the number of the adults examined. We would expect the same, because now if they had covered more households, the female had covered more households, we had number of more adults examined by female case finders in Kilindi than they were than the male's case finder. Again, I'm saying this is not a significant difference, as you can see from the numbers. Again, when we went further, so the number of suspected people, there was no any big difference. Like the number of male suspected that came to the outreach, the same for the female case finder compared to the male case finder. For both districts, there was no any difference. It was more or less the same. And also the number of women, the same thing for both districts in Chamino and in Kilindi. The female case finders that the women that were suspected by the female case finder versus the male that were suspected by the male case finders were also presented proportional the same in both districts. So what were we went further now into maybe now going further into looking at what were the criteria that were used for the selection of case finders, at least to get a bigger picture of both districts. Now there were common common criteria for both districts, which mainly were the case finder had to be able to read and write, and also given the work that involved a lot of walking and maybe staying longer without eating, so they had to be very fit enough to walk long distances and also be able to talk to the patients, examine them. There was a little bit of a difference in recruitment criteria. In Kilindi, they had opted to use village sub-village leaders because now these ones are the leaders. They are more listened by the community, but also they know their community very well. Mind you that every household was to be visited, hence they were trying to make sure that they don't miss the households in the area. In Chamino, they went further now, and just a mention here, most of the village leaders were male, so automatically we had more male case finders who were selected than female case finders to do the work. In Chamino, we realized that they even went further into asking now the community leaders to elect a few people from their community who they think that they will do the work, but then they did some interviews, like a formal interview for these people who wanted the job. It happened that the young male were more moved to actually apply for the said activity, and hence more young male case finders were employed in Chamino. So those are the criteria that they used to select their case finders in both districts. Like it was mentioned that the case finders' work were being shadowed from the training to the time that they were going through to do their activities. Now, while shadowing the case finders both in Kilindi, the female case finders were less active. We could maybe say because they are also less in the class anyway, but especially they were less active in asking and answering the questions. And we cannot say if this one had a big impact on their output. But also in Chamino, also the male, they were more active, and probably also this is due to social cultural differences, like I said earlier. So also during the practical sessions, we had male case finders wanting to be put more with their male counterparts, and the same it was with the female case finders during the practical sessions. So it was the male wanting to be themselves together, and the vice versa with the case for the few female that were selected to be as case finders. So during the process of case finding, I think I mentioned earlier also in one of our table, the coverage area and the time, the case finders from Chamino tended to have more households to cover against the ones in Kilindi. And like I said, like the terrain in Chamino happened to be different compared to the one in Kilindi. People were much more scattered. Houses were much more scattered in some of these areas because we had a chance to go around with them. We're also on the very mountainous area, so it took a little bit of someone's energy and time to walk further to these areas and do the work. One of the case finder in Chamino was asked, and she said, my area was good. The houses I visited were are clustered together, so she just did the same work that was done in Kilindi for 2 weeks. She did it for 5 to 4 days. Again, during the process of case finding now, the interaction within the household. It says here, in most of the household, when the man of the house was present, the case finders had difficulties interacting with other members, as when the women were very hesitant to be examined without their husband's consent. This was mostly seen in Kilindi also because you said we picked the Maasai community where the husband seems to has a much more say in the family to the women. And in some of the households where when the husband was not around, either some of the case finders had to convince the household members to be examined, and also if the husband was not around, they had to make a call maybe even a male child or a husband to give the consent. So it was a little bit difficult for some. I think I haven't mentioned here, but in Kilindi, in Chamwino somehow we found that the female case finder found it difficult to convince more the household, while the male case finder seemed to be a little bit more into wanting to convince the household to accept to be examined. Now, when we went further now into checking, what do they do? Anything happening after case finding when they suspected the cases? Female case finders were found to be more in touch with their work. They would find time to escort the patients, the TT cases that they had suspected. They would go with them to the outreach site and make sure they get the services. While for male case finders, we found it that it wasn't the case. Remember, in one of the male case finder that was asked in Kilindi whether they knew that their suspected case was examined, he clearly said he doesn't even know if that case reached to the area. So we thought female case finder took a little bit further action into making sure that the suspected cases were got the service that they required. Also, we went further into seeing what were the mostly challenges that were seen by the case finder. It says here, one female case finder in Chamwino reported that cooperation with the local chairman in the areas to be covered with house-to-house visit was a challenge. She said the main challenge were transportation and some chairman refusing to cooperate with us while visiting the houses. We sometimes paid for our transportation from our own pocket. I think that, as it was mentioned earlier, when we had a chance to observe the selection and the case finding process, the program made sure they also involved the leaders, mostly the village chairman, as part of the training, also to act as like they could help the case finders in case when they had problems. Now, most of the leaders are male, and when there was any challenge expected, that the case finder were asked to talk to the chairman, and this is what was found with one of the female female case finder in Chamwino district. Further, we went further now generally into seeing the perceived challenges among case finder. Now, this is general challenges that we're seeing, and I'll read them. Some of them complained of the long working hours and with no provision of large allowances. Like I said, this was mostly seen we saw this in Kilindi, where they had to walk longer distances to get into houses, and sometimes they would pass their large hours and allowances, so they complained about that. Some of the household members were not at home during case finding. This was one of the challenges that was faced mostly in the Maasai community, because some of them had to go to the areas to pasture for their cattle, and during the day while the case find was going through. And also some, like I said, that some refused due to fear or religious and cultural beliefs and suspicion that the team was there to administer COVID-19 vaccine, because this was a study that was done just after the COVID-19 endemic was there. And also, like I mentioned, when the husband were absent, it was difficult for some of the house members to accept to be examined. And of course, the language barrier. This was mostly in the Maasai community, when most of them were speaking Kimaasai, and some of the case finders could not speak the language, so that could also make it difficult for the case finders to be allowed to do their work, and hence less examination, less number of people being examined. And then, like I said, the nomadic communities, that during the case finding time, this community may have left the area to go and look for pasture, and they would come later when the case finding process was open again. So either the team had to go back, or it had to find ways to actually go and examine these people. And also the training was not adequate. Some of the case finders thought that if half-day training was not enough for them to understand the questions, and also it didn't give them enough time to get awareness on and be confident in answering questions while doing the case finding in the household. And also we went further into checking the perceptions of now the suspected TT patient. There were some perceived differences in how men and women reacted to the advice of the case finders. I'm reading here some of the case finder. This is the case finder from Kilimanjaro said, most men would ask why are the experts not coming themselves and set you to us instead. And most women would say, because they have stayed longer with TT, there's no need for treatment, that they cannot go to the farm after surgery. So this is a difference between a male patient and a female patient. And also most women were concerned about their husband, like we had said, and whether they would be able to carry out their household chores after the surgery. This is a response from a case finder from Geneau who said, if I get surgery and most of the time I work in the kitchen, how would I cook? I collect firewood and stay longer in the sun. How would it be? As it was reported by one of the Geneau case finder who was a male case finder. Some of the TT patients also feared, they show more fear and resistance. For example, a TT patient in Kilimanjaro say, people are discouraging us. You've decided to kill your eyes. I tell them, leave me alone. It's my own decision. The pain is reducing, but I cannot see well during daytime. But at night, I see things very clear. And when I complain about not seeing properly during the day, people say, you have decided to kill your eyes. I tell them, Shindwa Shaitan, that is a literal explanation, say, may the devil be defeated. That's a response from one of the case finder who examined the patient in Kilimanjaro. And again, another patient said, yes, I'm satisfied. And those who refuse this service are crazy. There's no one person who's waiting for me to recover so she can be, there's one person who's waiting for me to recover so she can be operated. Even in Songe, there are 3 people I know who ran away or were scared. Songe is one of the sub-village in Kilindi district. So this is some of the findings that I've decided we have given it to you. I think we'll have more questions to answer. So I will I'll now welcome Elizabeth to finalize the coming strength, and she'll start by giving strengths and limitation of the study, and she'll conclude the discussion, the recommendations.
Thank you, Fortunate, for a good presentation on the study findings. And in our study, we had some strengths that we worked in 2 districts with sociocultural characteristics. We worked in 2 different culture. We used a multitude data source and method. We had qualitative data and quantitative data. But however, we had some limitations in our study. And one of the biggest is the context, which is not transferable to another. Each context was different from another, but with different people, with different culture. But we wanted to get answers to both of the community. So context was among the limitations that we found it's alarming. As a conclusion, the study
Hello, apologies for a frozen screen. May I check with the audience? I'm so sorry. If someone could put in the chat whether they think it's my connection or the speaker's connection that may be frozen, that would be very helpful, because mine's been up and down as well.
Marianne, I can hear you. I don't think it's your internet. I think it's yeah. So
okay.
Maybe we'll give them a few minutes.
Thank you so much, Grace. We've had problems on our end as well, so I wasn't sure if it was frozen for me. Speaker. Thank you, Razia, and thank you, Edward and Christina. Okay, I'll just give, I think it was Elizabeth's connection that we were on. I'll just give it a few minutes, and then if not, perhaps Grace, you might volunteer to read the conclusions. I believe it was the last slide, but no, it wasn't the last slide. Sorry. Let's just give it a minute.
Okay. Yeah. If they are not able to, I'm happy to conclude. But let's give them a few minutes first. Yeah.
Unfortunately, I see that Robert has left the room, as the system sometimes says. And earlier today, there was an electricity cut. So that might be what's happened. I'll just check if they've sent a message. Thank you, audience, for being patient. We love doing these live. We think that's much more spontaneous and collegiate, but then we are slightly at the mercy of unstable connections. So just give it a second. Oh, Robert's joined the room. We're on the right track. It's going to be fine. Hi.
Sorry, the connection dropped.
Oh, yeah, we were just discussing that. This is meant to be a relaxing experience. I'm really sorry that there's been a lot of effort, unnecessary effort from your side, but thank you.
Yeah, we had some connection issues. So it was the conclusion. So the qualitative evidence suggests that female case finders were among the most active in supporting suspected and confirmed TT cases. There was a strong verbal commitment among female case finders to follow up with suspected and confirmed TT cases beyond the initial case finding phase. And for men, it was sometimes you would find the cases themselves, and until when you ask them who identified you, then they mention that so and so identified me, but you wouldn't find them at the service centers. So we found the women were more into connection with their clients compared to men. The programs may benefit from integrating gender considerations in the design and implementation of case-finding campaigns, in monitoring gender differences among case finders and the relationship with key outcomes, in ensuring an adequate balance of female and male case finders based on the different contexts, and last, in the training of case finders, as they are often faced with situations where women with TT are not empowered to make decisions to be examined and accept surgery. So the evidence from this study suggests that the training on counseling offered to case finders could be enhanced, and ideally always offered in the first language of suspected TT case or groups of suspected TT cases. As we have seen during the methodology presentation, we found that the case finders were shadowed. So we observed that they were struggling to convince the TT cases to accept services. So we thought maybe with an additional of the counseling to their training package, that would enhance their case finding processes. Thank you for your attention.
And also, we just want to acknowledge the support from the different donors. So this study was made possible with support from Sightsavers International and the Elton Foundation. And this was done in collaboration with the Ministry of Health and the Congo Trachoma Project, which will deal doing the TTK standing in terms of the TCO was responsible for killing. Sorry, with the technical difficulties, it has taking a bit more time. So I hope there's still time for questions.
Absolutely. And I'm sure the audience will join me in giving you a massive round of applause, and also for saying a huge thank you for sharing this wonderful work with us. We know that women are at a disadvantage when it comes to healthcare. As primary caregivers, they're often exposed disproportionately to pathogens. They then face disproportionate barriers to accessing healthcare, and even medical textbooks are written really with men in mind. So this really is a momentous body of work, really, in the right direction. And Robert, you started off by reminding us of those elimination targets, and one often says that as we approach those ambitious targets, surveillance becomes a challenge, and maybe that's thought of more often in terms of the technology, the diagnostics for surveillance. But this is a really important part of that surveillance to bring us closer to those targets, to make sure that they are maintained, and even in a post-elimination setting, really sticking to those huge progresses. So thank you, and so much to learn from that, not just for trachoma, but also lots of other diseases and just healthcare systems in general. So thank you very much. There have been a couple questions come up during the presentation, and just to quickly answer Nicola, who's asking about whether the slides will be available. We do record our webinars, and they will be available on our website or on our YouTube channel. So please do take a moment to revisit anything you may have missed. So another question from Nicola, the first question that came up was to ask about, in terms of how you were doing the surveys, whether the households were detected or chosen before going to the field, or once you were in the area?
So Fortunate, want to answer the way it's done? So the goal with the case, anyway, I'll let you start.
Oh, you can just come out.
Oh, so with the case findings, the goal is to visit every household in the area. So there's work done with the local leaders to map the community in a way. And then based on the number of the case finders that are trained, they divide up the work to make sure that each case finder knows exactly the area they were responsible for. So there's no selection. So we're not talking about a population-based survey where they take a sample. With case findings, you have to cover all of the households, and ideally all of the people 15 plus should be examined. And then if they keep a list of the suspected PT cases, and then they encourage them to attend the outreach so that the diagnosis can be confirmed if it's TT or not. And if it is a TT case, then they are offered the service. And even if they refuse, they are now considered to be known to the health system. They may come back later and say they want the surgery, but this is the thing with the trachoma target that is interesting, is that we want to have a prevalence that is below 0.2% of cases unknown to the health system.
Yeah, so just to further say, so we went into different sub-villages. So whoever that case finder that was working in that sub-village automatically was being shadowed. So we went like we had mentioned earlier, we had chosen these populations based on their cultural differences and the geographical differences. So for example, for Kilindi, we had chosen the Maasai community and certain sub-villages that were working, they were doing the work during the time of the study. were picked, and whoever that was working in that particular area that we were visited was shadowed. The same thing happened for Chamwino.
In Chamwino, because the case finders were many, so we couldn't shadow all of them. So we picked some of them and we shadowed them.
Male versus female.
Yes, male versus female.
Fantastic. Thank you so much. Martin Coleman also had a great question. Good afternoon. Martin saying, how did your KCO team handle other eye diseases that are often presented or identified during TT screening?
Okay, for the case of Kilindi, so other eye disease that was mostly commonly presenting was cataract. The good thing with the Kilindi district, there's a comprehensive eye activity going on. So what happened is the surgeons who were doing the screening, if they come across the cases like cataract, they would have written them down and then refer them to the existing system of outreach that is in the place. And that is what was happening in Kilindi. I'm not so sure about Chamwino, but I think more or less the same thing happened. And for some instant cases like allergies or what, there were some of the eye drops that were given to those that presented. And if for cases that needed further management to further referral hospitals that were nearby, for the case of Kilindi, we have Tanga Regional Hospital and Kilimanjaro KSMC, which is the referral hospital in the region, then they were referred accordingly.
Yeah. So like we currently work in Ngorongoro districts for TT case findings, but then the cataract cases are identified. And then we have another program that supports a cataract surgical outreach to serve those patients.
Yeah, and in Chamwino, the team has connections with the outreach camps, the cataract outreach camps. So whenever they come across with other diseases from TT, they'll just register them and refer them to these outreaches or direct to the services in regional hospital or in a district hospital. But as Fortunate said, the minor cases like allergies, they were given some eye drops on spot.
Interesting. Thank you so much. John Akani is asking, what about the issue of age?
So is it possible to clarify the question? Is it in relation, for example, of mobility issues in reaching the outreach camp, or?
Well, John, if you don't mind, yes, if you could elaborate a bit what you meant by age. I assumed that perhaps it was whether, in addition to gender of the case detector, whether the age of the patient also affected that relationship with the team. But John, please, by all means, do let us know exactly what you're asking. Or maybe the age of the case detector as well.
Yeah, so I don't know, maybe, so we did not find differences with the age of significant differences in the age of the case finders. I don't know for Fortunate, Elizabeth and Grace who were in the field, if you have found when doing direct observation, when you were shadowing case finders, did it seem to make did you have any observation whether the age of the case finders versus the patients was something that you saw differences?
Yeah, maybe I can give a little overview of. So this is a question we also asked the program managers whether the age was something they considered, especially given the fact that it involved a lot longer distances. Mm-hmm. In now 1 or 2 instances we came across. I happened to shadow one older woman who it was a little bit difficult for her to walk to longer areas. So generally that we cannot say a lot because we didn't come across a lot of differences in the age, but for the instance that we came in, that was one thing. But at least we had a chance to question the program managers and the ones who were involved in running the activities. I think that's something they also consider while deciding who should be a case finder based on the type of job. Maybe my colleagues can also put a little bit of this.
Yeah, for Chamwino, since it was they were not voluntarily picked, they were supposed to apply to be a case finder, and they were interviewed. So in the advert, they put the age limit from above 18 to 35. And I think the reason behind is the work itself, because they had to work longer distance, like for an elderly woman or man, that could be a bit difficult. But interestingly, because they were working with the area leaders, those leaders were a bit older. So sometimes when we were shadowing, sometimes the leader would say, no, I'm tired. Maybe I could just direct you to other areas that belongs to my part, but you go on, I wouldn't be able to work with you, because it needs some energetic people. Yeah.
Wonderful. Did you find that elders amongst the patients were more likely to support your team, or perhaps help you reach out to other members of the community? Was that a significant characteristic of your tasks?
It was obvious, because in some areas you would find these elderly would hide their fellows. It depends, the perceived need of that service. The person, if they think that the services is very important to them, then it would be easy for them to share information about their fellows to the next door. But if they are negative about the service, obviously they would also hide their fellows, because with this technology and phones, sometimes they would notify their neighbors that these people are coming for ABCD, hide your grandma inside, something like that.
That's very interesting. Before we move on to an excellent last question from Razia Kwalate in Mwanga, I just wanted to take a few minutes before our time is up to just ask you or find out a little bit more about what it's like in general at the Kilimanjaro Centre for Community Ophthalmology. It is a WHO collaborating center, and it's world-renowned. And tell us a bit more for anyone who does not know you or has not visited. What is your center like, and what are its strengths? What are some of your main partners? We would love to discover your organization.
Oh, thank you for the question. So we, unlike other NGOs who work on trachoma, but also in the area of NTDs in general, for us, our focus has been on trachoma. We're really about community ophthalmology. So we don't have a broad NTD agenda. We work on trachoma and then on comprehensive eye health programs. So we work in 7 countries, including on pediatric eye care, in Francophone Africa as well, in Madagascar and Benin. And so we, when we work with partner hospitals, mostly regional hospitals or zonal hospitals, and we do some capacity building, work on cost recovery and financial sustainability, quality of care, of course, and more expanding beyond cataract to also tackle conditions that are becoming more common, like glaucoma and diabetic retinopathy. And so the what's interesting is that the work of training TT case finders for trachoma is also something that we do for other conditions, like for pediatric eye care, train key informants at the community level so that they can identify children with vision loss, including cataract, because of cataract, as early as possible, because the sooner you manage them, the better the odds of a good visual outcome. And we work also with microfinance women groups to give them basic training on eye health, and they actually act as also cataract case finders in the communities. So there's a lot of our work is building bridges with communities, whether it's to identify and refer cases of trachoma, but also other eye conditions.
Yeah. That's fantastic to hear, and a big motto in the NTD community is always to integrate with other diseases, and so this is an amazing example of an organization that's doing exactly that. Would you like to add something, Elizabeth or Fortunate?
I think I mentioned about the fact that we're a WHO Community Center. So
yes,
some of our work over the past year has been to complement the work of NGO partners and WHO in helping countries write their trachoma elimination dossier. So which is the document that they must submit to the WHO that then gets reviewed by independent experts to validate that they have reached the three criteria. So we've been organizing with the support of different NGO partners, regional workshops to help countries with the dossier preparation.
Wow.
So,
and lots of good news in that field as well. So you must have been very busy.
Yes, so countries have done a good job. The West Africa, some Mali and Benin in recent months with their validation. So it's progressing well.
Yeah, maybe just a little addition, like you said, like in locally with our local partners, we work really also with some other NTD organizations, especially in trachoma elimination within Tanzania. We work with other partners like Site Savers, Helen Keller, and also we normally have we convene on quarterly basis to share our experiences of elimination of the trachoma in terms of NTDs, but also general, as Robert may have mentioned, we work in close contact with the community health facilities, primary health workers, and some of the local surgeons and community health workers. We train them into general comprehensive eye health, and we have put a lot of emphasis also on working with the community. So like he had mentioned about working with the microfinance women as case finders, but also key informants, and also training teachers in schools and schools for the blind, at least to make sure that we have the basic, the lower group of people, the children are not also left out in terms of general eye care awareness and the services available.
Yeah, just the name itself, Community Ophthalmology. So we are really into the community. Yeah.
Definitely, and so many lessons for lots of other diseases as well from your way of doing things and your collaborations. And you have inspired the audience. John Olajide is asking, can someone come to your center for research visits? So,
of course, of course.
You're most welcome.
I have no doubt from this amazing team that everyone would receive a very warm Tanzanian welcome. Grace, over to you. You work also with Peak Vision. Could you tell us a few words about this organization and what your role is there?
Yes, absolutely. And before I do that, Marianne, I was wondering whether it would be good to respond to the question on the key takeaway by Razia.
Yeah, absolutely. So we will end on that question.
Okay.
We had so much food for thought from this amazing session, and I thought the key takeaways will be a lovely way for us to really think about everything we've discussed today.
Okay.
So
perfect.
Up to you for Peak Vision or takeaways.
Okay, I'll talk about Peak Vision. So I'm honored to work with KCCO, the amazing team from KCCO, as a consultant in this project and other research projects. I also work with Peak Vision, which is a social enterprise which is based in the UK, and we look to power eye health programs to strengthen systems and service delivery with a unique software and a data intelligence platform. We don't directly implement eye health programs, but rather we work through implementing partners ministries of health, NGOs, among other stakeholders, to be able to reach, especially the hard-to-reach areas where eye care services are not able to get to due to challenges such as the terrain, unavailability of equipment, the limited human resources, among other very well-known challenges that prevent populations that are in need from getting the services that they badly need. So that's in a nutshell. I would invite everyone to go to peakvision.org to read more about us, and feel free to shoot us an email, contact us via the form provided, and we'll be happy to get back to you and let you know more about what we do.
Thank you, Grace. And absolutely, to quote Razia and her question, Razia says, "Thank you, Team Chamwino and Kilindi. Great research and findings." Nicola Kashama also said, "Good presentation. Many thanks for the team from Tanzania." And Razia's asking, what were the overall lessons learned and the way forward? What might be really the key takeaways that you would like to leave our audience with today?
So at the risk of using a cliche, we think that further research is needed. The qualitative research, I think, highlighted some interesting differences between male and female case finders. And one thing that is very important for trachoma program is that once you have a list of suspected TT cases, if you are using full geographic coverage to validate that you've reached elimination, you cannot have 50% of the people suspected of TT to go to the outreach, and you lose the other 50%. Some countries have adopted criteria that at least 90%, for example, of the suspected cases need to be managed and seen by a high health professional. So you need to reach, the vast majority of your suspected TT cases to be examined. And so there was a trend when we looked at the qualitative data that the women case finders were more invested in staying connected to the suspected TT cases and bringing them to the outreach. So then after that, they are offered a service, they can still refuse. So there's a level of engagement by women case finders that emerge from the qualitative findings. Now, the quantitative, which we look at all of our indicators, apart from the number of days and the confidence intervals are wide, the results were not statistically significant. Yeah. And it's explained partly because the sample size from Kilindi, with the time that we had to do the study, we had to look at the schedule of districts that were about to start activities, and we wanted to have Maasai community represented. Kilindi was there, but Kilindi, we didn't have a lot of retrospective data to work with. Yeah. We only had 2021 and up to a certain point in 2022, while some districts have data that goes back, like Geneau, all the way to 2016. So if we could have had a more retrospective data to work with, maybe we would have been able to confirm some of those differences that we've seen with the descriptive statistics. So it would be interesting to replicate this study in other countries that may also have the same question in mind, whether they should recruit 50-50 male-female case finders, or what makes sense in their settings. So I think we see some trends emerging from this research, and would be interesting to see if it could be replicated elsewhere.
Wonderful.
Maybe Grace has something to add?
Yeah.
No, really, actually, Robert has captured it very well. I think, as he's mentioned, the data that we collected is not enough to make generalizable recommendations, but we also found that programs such as this may benefit from applying a gender lens in their design and implementation to be able to see whether there are any differences in the outcomes and outputs for male versus female case finders. But in order to generalize this, definitely more data will be needed, and in that case, more research will be needed. But overall, it was an interesting study, and I hope everyone gets to read our paper and see more of what we found out, because we couldn't present it all today. Thank you.
We did share one observation with the ministry that the training session, it's a very short time that is allocated for the training of case finders, but there was no, we think it would be useful if there was a acknowledgement of the gender consideration with this work. So the challenges that they may face in, visiting a household, and when the husband is not present, that they, there's a need to go back sometimes. So the gender aspects are not part right now of the training sessions, and it does not to be half a day, but it would be value, we think, in bringing the gender consideration into the training of case finders.
Yeah. And I'll just putting a link to the paper in the chat. So Marianne Kuij saying, wonderful team. And couldn't agree more. We've had such a wonderful hour and a bit with you to get to know you. It's been an absolute pleasure. Your work is really immense in terms of bringing gender disaggregated data and also just more generally gender representation equality in healthcare systems. So I am sure we will all keep in touch with the Kilimanjaro Centre for Community Health, not just around TT and trachoma and your work in that field, but also more generally in eye care, one of the biggest global inequalities really in global health. So it's wonderful to hear all the work you're doing in all these different fields. So one last time, a very big round of applause and a thank you. And if there are no more questions from the audience, then there's never enough time, but we will bring this session to a close. And most importantly, I hope we can keep in touch. Please don't be surprised if you get a coach of visitors coming very soon, because I think we all want to join you and meet in person. But until then, I wish you all the best. And thank you so much for your time today, for sharing your work with us. It's been a pleasure.
Thank you very much.
Thank you. Thank you so much. Bye.
And lots of nice comments coming through on the chat as well. Edward De Antonio, very nice. Christina Juan, thank you so much. Absolutely. All right. Well, all the best, and let's keep in touch.
Thank you very much.
Bye. Thank you.
Bye.